Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi channel via Facebook, YouTube, Instagram, Twitter, and also the Dr. Fundi website. My name is Fundi Lenyati. I'm the host of the channel. Today, we have an interesting conversation in prospect. Today, we have a special guest, Mr. Mark Heywood. I don't think he needs to be introduced to many of you, but it's customary that we give you a short bio of our guests. So I will do that. Right. So Mr. Mark Heywood is a veteran South African human rights and social justice activist. He's an Oxford University alumni where he studied English language and literature. Came back to South Africa at Wits University. He studied African literature. He's been a political activist since the 80s when he was still in England as a member of an organization called Militant Tendency. And he came back and continued here in South Africa as a leader of Marxist Workers' Tendency of the ANC. Post-1994, Mark joined the AIDS Law Project alongside Justice Cameron and Zaki Ahmad. He's been, an activist in civil society spanning the whole period of our democratic dispensation in South Africa. And in 1997, he was the head of the AIDS Law Project up until 2010. And later, he co-founded Section 27, which is a public interest law, center that seeks to influence, develop, and use the law to protect, promote, and advance the human rights. And that incorporated the AIDS Law Project. That was in 2010. He was one of the founders of the Treatment Action Campaign in 1998. Just hold on. Right. There was just some technical issue there. He was one of the founders of the Treatment Action Campaign in 1998, and also the AIDS and Rights Alliance of South Africa, ARASA, Corruption Watch, Save South Africa. He's got extensive experience in constitutional litigation to realize the rights. There are a number of cases that he was involved in, the Hoffman case, the TAC case, during the time where they were forcing the government to make sure that, ARVs are made available to those who qualified. He has published extensively on HIV, on human rights law and politics, both in the academia and also popular media. He is currently the editor of Maverick Citizen, having stepped down from Section 27 in May 2019. So that is the bio. As you can see, it's a long one, but welcome, Mark.
Good afternoon, and thank you very much for having me, and good afternoon to the viewers and listeners. Thank you. It's great to be with you.
Lovely, lovely. Thank you very much. Just to kickstart our discussion, we already hear from the bio that already by the mid-80s, by the 80s, you were already a political activist, human rights activist. Then just tell us, how did you get to that space?
That's a long story, but I grew up in different countries of Africa, in Nigeria, in Ghana, in Botswana as a child, and freedom was always important to me.
Yes.
And when we lived in Botswana from about 1977 for a few years, being very close to South Africa, which in those days was obviously at the height of apartheid and the height of the oppression of the that came in the 1980s, I was struck by Steve Biko, actually. I think perhaps the thing that kind of jogged me into thinking about politics and thinking about justice was the murder of Steve Biko in 1977. And then I began to find my way to understanding issues about human rights, about justice, about non-racialism. And perhaps it wasn't my life plan, but it became my life plan, or it became my life. And you know, in the last 20 or 30 years, they've gone by very quickly. But you know, before 1994, it was a struggle for political rights, for freedom. But what I've really understood since 1994, and of course because of the HIV epidemic, was how central health and good health is to people's dignity and to people's opportunity. So I guess almost by accident, on that understanding, I became an AIDS activist and a health activist. And that's what has characterized my post-1994 life.
Yes, but although, you know, we now have seen you, you know, broadening that space within the continuum of social justice beyond healthcare. You know, whilst many would have known you, you know, a lot around stuff that's happening in healthcare, but now, especially when you were with Section 27, you guys were taking up issues around education, and you've taken other issues as well, you know, which are quite important in our country.
Yeah, and I think the explanation for that, as you will know very well as a doctor, is that education is a determinant of health. Corruption is a determinant of health. If the resources are being stolen out of the healthcare system, people can't get medicines, people can't get medical technologies, then their right of access to healthcare services is denied. So all of these things are linked. And I guess, you know, my evolution was that in the 1990s, you know, it was a life and death struggle around HIV treatment and the 2000s. And we just had to fight to get those, we had to campaign to get those medicines to people, because if we didn't get them to people, people were getting sick and people were dying. And you and I knew many people who did in fact pass away because of AIDS. But you know, once we'd succeeded collectively through the Treatment Action Campaign and others in ensuring an antiretroviral treatment program, I guess you had to ask questions about the sustainability of the health system, the funding of the healthcare system. You know, it didn't make sense to fight for antiretrovirals to prevent mother-to-child HIV transmission, but then have little children dying at the bottom of pit toilets. So it was about quality of life. And for me, you know, in South Africa, with our constitution, we had an instrument at least that we could turn to try to make these promises into something much more real.
Yeah. And how difficult was it, though, you know, to actually have to take a government that is led by the majority party, of which, you know, obviously, you know, for most of your struggle years, you know, or activism, you were actually part of it?
It was difficult. It tore you in half at times. Again, you remember, you know, in the early 2000s, you were much closer to 1994. If you were critical of the ANC or the government, some people considered you a traitor. In fact, we were called agents of pharmaceutical companies and so on for fighting for the medicine. So it was difficult politically, but, you know, it was also difficult personally in some respects. I mean, before, you know, the darkest days of the AIDS epidemic, actually had quite a good relationship with Dr. Mantu Shabalala Msimang. You know, we worked quite closely together. So to end up being pitched against each other was not easy. And I think that's what people don't really understand about the Treatment Action Campaign, because many of our volunteers, many of our activists came out of this very same tradition of the liberation movement and the liberation struggle. But I think we passed the test, because the test after 1994 was not blind loyalty to a party, but loyalty to the Constitution. And that's what we had to tell ourselves.
Beautiful, beautiful. So yeah, so today we will focus more around issues of mental health, and maybe if we have time still, around issues around the healthcare infrastructure, its maintenance, and the downside when it's not being maintained, right? So about 4 days ago, we heard, from NPA that from the 19th of July, there is going to be, the commencement of the formal inquest into the life Esidimeni. Now, I would want us to start, backwards though, at the point where, a decision was made by the Gauteng Department of Health, which led to, a lot of problems. Then, the health ombuds came in and made his recommendations that led to the arbitration process through Judge Museneke, and the awards that came from that eventually are now, obviously he did not, make anything in that space around around the criminality. He raised issues, but he wanted the relevant parties to move with that. So maybe can we just go back then to say, as a person who was part of Section 27, which played a huge role in supporting the families of the mental health care users, when you first heard about this situation of people who were being taken out of the life Esidimeni, and people dying, and I mean that was in 2015. How did you find that situation before you guys took it up and felt, all right, we are going to be on the side of the mental health care users?
Well, I think that's the tragedy, that life Esidimeni could have been prevented. And those 144 deaths at least took place because the Gauteng Health Department and the then MEC, Qedani Mahlangu, did not listen to NGOs, to users, mental health care users and families, because Dr. Nyati, from 2014 and throughout 2015, people were trying to persuade the health department not to close life Esidimeni. The South African Depression and Anxiety Group came to us at Section 27 and told us what was going on. There were meetings, there were letters, there was an attempt to bring a court interdict to stop people being moved. I myself negotiated in the December of 2015 with Dr. Barney Celebano, who was then the Gauteng head of health. We thought we had an agreement that nobody would be moved. But for some reason that even Judge Moseneke says he never got to the bottom of, there was an intention to go ahead with closing this facility. And that we'll come to the inquest in a minute, but I guess it's what was the real motive is one of the critical questions that will have to be looked at.
Yes, I'm actually quite interested in that because, I mean, when I was reading the arbitration, documentation, it still was not clear what the real intention was, because all three reasons that they gave, they were found not to have a basis by other witnesses.
Yeah, and Justice Moseneke said that the real reason has not been given. He said that in his award. If you want to know what I think was the real reason, I think that the real reason was to do with corruption. I think it was to do with political patronage.
Yeah.
because by closing Life Esidimeni, the then MEC indicated to a number of supporters and so on in different parts of Gauteng, if you move fast, you can set up facilities. We'll be needing places where mental health care users can be looked after in inverted commas. I think that there was a corrupt motive. I think that there were individuals in those NGOs and others who probably benefited materially, substantially materially, because for me, there can be no other explanation why you ignore the advice of the experts, you ignore all of the warnings, you're so intent, you are going to go ahead, come what may, you are going to go ahead and do this. And I hope that this is something that the National Prosecuting Authority has been probing since the arbitration. Because certainly there are clues, certainly the arbitration, Justice Moseneke's findings held out lines of inquiry, if you like. You know, we know.
For example, that, you know, even after some of these NGOs were closed, but they continued to be paid.
Exactly.
And also, you know, a lot of, you know, untruths. You know, I mean, the issue about National Treasury, or sorry, not National Treasury, the Auditor General. You know, that the Auditor General has raised a query around this evergreen contract, and yet when Minister or MEC Barbara Creasy then came back and said, no, she has looked at all, you know, the AG reports for the department, and there's nothing like that. So, as you are saying, the issue of possible corruption, it cannot be far from, you know, the motives.
Yeah, that's right. I think it's got something to do with corruption, you know, and it's also just got, it really tells us a lot about political failures and political accountability, though, because I have to say, you know, when we were failing to be heard by the Gauteng Health Department, we attempted to make the Premier act. We attempted to make the Minister of Health, Dr. Aaron Motsoaledi, act. So, you know, the systems that should have been there to put brakes on also failed. And that tells you something as well. And that is why, you know, when Justice Moseneke published his judgment, I felt at the time that judgment, and I still feel this, should be read by every single politician in this country and every single public servant, because it speaks so much about public service and the responsibilities of public service. And it also makes it very clear that public servants' responsibilities are to the Constitution and are to patients, that where there's a conflict between a political instruction and the best interests of the patient, the best interests of the patient must come first. And I think that is so crucial. And the judgment is, you know, obviously very well written, it's very clear, it's very painful to read because it tells about the death and the suffering and the torture that so many people went through. But we shouldn't allow it to be something that is just stuck in law books and poured over by academics and lawyers. It's a very real, live, necessary piece of paper for all people who are involved in healthcare provision.
And one thing that came through, you know, when the guys were giving evidence, I'm talking about the senior officials, was the fact that, you know, each one would say, no, I got an instruction from above. You know, an instruction from above, and I could not contradict my political head, you know, yet you are an HOD, an accounting officer of a department, and you have the powers to actually, you know, say, no, this instruction I am not going to execute. So therefore, the issue of politics behind can't be far.
No, there's always politics, and that's what we need to do, is to separate politics from public service. And it's still an issue. I mean, we saw it in relation to COVID-19 and corruption. It was an issue before life esidimeni. It's an issue after life esidimeni. It seems we haven't learned the lessons. And I can't understand why we can't teach these lessons. You know, we're a country with a strong communication systems, with public service commission, with politicians, political parties, etc. Why can't we get beyond a disaster like that, learn the lessons, and make sure that it never can happen again in any shape or form?
Yes, 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 yes. So, I mean, when one looks at this ECD thing, you mentioned that 144 lives were lost of mental health users. And when you compare it to Marikana, which is also another, blot in our democracy, it's almost 4 times Marikana in terms of the death toll, but also the other people who survived. There's many of them who actually went through a lot of trauma. I mean, there were almost 2,000 people at Life Esidimeni, and at least about 1.4 to 1.5 people are traumatized, and others, they got other kind of illnesses, morbidity as a result of the whole thing. And so it's so much more than Marikana. Yet, I don't think we are actually putting it in the level that it should be looked at as one big blot, in our democracy.
I agree. I think it was a defining moment in our democracy. And 144 lives, it's not over. The people, family members of people who died, people who themselves were transferred, are still suffering today from that experience. And partly they're still suffering because they don't feel that there's justice yet, and they don't feel that there's truth. A lot was achieved, and the arbitration was very, very important in many respects. But as we said a few minutes ago, it left unanswered questions. But, I think there's a deeper problem, Dr. Nyati, in our country, is that we surrender life too easily. We allow these things to happen with impunity too easily, and we allow it in the health service. I used to write in relation to health that there's a mini Esidimeni happening every day now in the health system. You take COVID-19, a lot of people who have died because of COVID-19 did not need to die because of the virus. Yes. They died because the health system was not adequate to care for them. And it's a significant number of people. Our official total of deaths, as you know, is 55,000, but the excess deaths that are due to COVID recorded by the Medical Research Council is now 154,000 people since May of last year. So, our constitution says we must value each life. Each person has a right to life. Each person has a right to dignity. I don't know what it is. I think it's perhaps something to do with our trauma, to do with our psychology, our past, but we're too quick to move on and not learn the lessons. And not only not learn the lessons, but not change.
Yes. And I mean, what you just mentioned now about the death toll, which at face value, you think, oh, it's 55,000. When you compare to other countries, no, it's not so big. I mean, others have got more numbers. But if you add the excess deaths, and like you said, every death should have been, some that saved. Now, I originally come from the Eastern Cape. And when you look at the deaths from COVID per 100,000, population, comparing all our 9 provinces, you will then find that those provinces with the more dysfunctional healthcare system, like my home province, the death toll per 100,000 is just so high.
Yep.
You know, even Free State, many people don't know that the death toll in the Free State, you know, was quite high, you know, and it's still continuing. Western Cape has only just in the past week overtaken the Eastern Cape, but still, when you look at the numbers, you can't help but understand that where the health system has been very poor, you know, then the whole issue of you know, inequity in the healthcare system, you know, has been exposed by COVID-19.
Exactly. I mean, your province, if your province was a country, it would be the worst affected country in the world. Not just the worst province in South Africa, it would be the worst affected country. The case fatality rate in some parts of the Eastern Cape was 12% at the peak of the second wave. And, you know, wearing my hat as the editor of Maverick Citizen, we have been investigating the Eastern Cape Health Service. We've written a lot on it in the last 2 months. Our reporter Estelle Ellis has talked to doctors, talked to patients. You know, all the reasons are there. There's nothing mysterious about it. Yeah. But you know, what is again frustrating? I mean, I remember back in 2012, I think, helping to start a coalition called the Eastern Cape Health Crisis Action Coalition.
Yes.
Because of the problems we identified in the Eastern Cape in 2012. Yes. And the shocking thing is 10 years later, the problems are worse. So it's a bit like what we were saying about us trying to get the Gauteng Health Department not to close Life Esidimeni. Activists and NGOs and people have been pointing out the crisis of the Eastern Cape health system for a decade, but almost nothing has been done. And corrupt people still run that health system.
Yes.
And that's terrible.
Yes, I mean, in the middle of a pandemic, you have, you know, irregular contracts of scooter ambulances. You know, that 10 million could have been better used. You know, yeah. I mean, most of the hospitals, especially the, you know, the district ones, didn't have oxygen supplies.
Yeah.
You know, didn't have, so a lot of people died, those who managed to get to hospital without, you know, being able to access oxygen, even where it was there, replacement canisters, or, you know, to make sure that there's continuity of oxygen supply were not available. So it just tells you, obviously, it is functionality within, you know, the province. Now, so when we look at all of this, Mark, what do you think, you know, now reflecting also on the award, you know, and the judgment by, you know, Judge Museneke, what lessons from a governance point of view should have been learned that should not have been repeated?
Well, I guess the lessons are always act in the best interests of the patient, have strong governance systems and accountability systems. I mean, one of the things that was implicated was the mental health review boards, yes. Which weren't functioning properly. Listen to patient advocates like NGOs, and monitor what is going on in your healthcare system. Yeah. You know, it shocks me sometimes that little NGOs can tell government more about what is happening in their health system than they know themselves, even though they have a budget of 250 billion rand a year. You know, a few little NGOs working on a few million rand can sometimes tell you better about your medicine supply systems, about your HR shortages, about your infection control challenges, etc., etc. And there's a problem there. So there's a lot. There are many things, and I think that's, you know, you're a health practitioner. That's our frustration in this system, is that many of the things that we see going wrong don't need to go wrong. If you took little fixes here and there, if you paid more attention, this crisis that we face is of our own making. It doesn't have to be. It does not have to be. We are a country with by comparison with many developing countries, an advanced health system, public and private put together. We have some of the best medics, clinicians, hospitals in the world. So our outcomes are that there's no justification for them.
Yes. Safe to say, maladministration, corruption, incompetence, the very issues that Judge Musenege actually highlighted, that, he picked up a lot of that, a lot of those things as the things that are throwing back the healthcare system. Now, obviously, his judgment was around the Gauteng Department of Health. But that could have even been any other province, like we said. You talked about mini SCDMs on a daily basis. So the findings of issues around mental health services in Gauteng, when we now try and look at that, in terms of the broader country, one of the things that still is an issue for me is the fact that yes, delivery of healthcare services, the mandate is at provincial level. But what role, because when you even look at the judgment, there isn't much directed at the national department, and certain policy decisions are taken at that level. Do you think the judge should have gone a little bit further to look at the role that national department and the policy that was claimed to be the one that made them to look at the institutionalization?
Perhaps he could have gone a little bit further. I mean, he did comment on it, but he didn't spend too much time. It may have been helpful for him to go further because he's a preeminent constitutional lawyer, and I think he could have knocked down the excuses that are given by the National Health Department. Minister Motsoaledi always used to say, but the problem is that health is a provincial, it's provincial competence. There's nothing I can do. I have these bad MECs. There's nothing I can do. But we're not a federal system in this country. National has core responsibilities, particularly to ensure maintenance of standards of care. So I think that the reasons that are given are excuses. There's not an actual barrier in law to national ensuring that provinces stick and maintain a certain standard. Now, of course, as you know, on a day-to-day basis, provinces run their health systems.
Yes.
We can't get away from that, and that should be actually better because it takes the health system closer to the people. But where you see that a province is abusing its health system, then you can step in and then you can take action. And the other thing we shouldn't forget in here is politics as well. I mean, it's the same political party that runs 8 out of 9 of these provinces. It is a party that tells us that it stands for poor people and poor people's rights. So that political party is very capable of redeploying somebody who is inefficient or incompetent, or moving resources into a province, or appealing for assistance in a province. So I'm not suggesting that these things aren't difficult to some extent, but I am saying that they have answers. And what we're given a lot of the time is excuses. And I think politicians should be more honest with us. They should come to us and say, okay, we have a problem here. Come help us to solve this problem, rather than it being like something that is behind closed doors within government or behind closed doors within the ANC, because that means that the people who pay the price of the behind closed doors stuff is you and me. Well, not you and me, because you and me are able to access decent quality medical care. But people who are not privately insured, who are wholly dependent on the public healthcare service, very often it's a lottery.
Yes. All right. So now, just going back to that judgment, the role, even before the judgment, actually, from the health ombudsman, they highlighted a handful of people, who were actually instrumental in making sure that this decision, which he says was irrational, which he says, should not have been taken. There were three people: the MEC of the time, the HOD of the time, the director of the mental health services in the province. Those three, he says, their fingers are everywhere when you look at this whole thing. And I guess that's where people start to say the arbitration, some were expecting that there would be something that will hold people accountable, and it didn't, get to that level. So are we then, as we are now saying there is going to be an inquest in July, from the 19th of July, do you think that, it might get to that point where some of the main players are held to account, and where maybe there's criminality, there may even be, cases coming out of that?
I hope so, because if that doesn't happen, then the inquest will just be rubbing salt in the wounds. The inquest will just be requiring families again to once more relive the trauma and the pain and so on. Something has got to come out of this inquest. That the arbitration was a civil proceeding. I don't have Moseneke's judgment in front of me, but he was very clear that he felt that there was causality, that there was criminality, that there was a need for further investigation. And we know, you've named them, we know the people who who must answer for that. And I hope that some of those people end up in prison, frankly, because they caused the loss of so many lives. And I hope that the whole truth comes out of that inquest. But I also hope that when the NPA conducts it, it's done efficiently and it's done swiftly, because it's too painful for many people. I've been speaking, I still stay in contact with certain family members, Christine Nkomalo, whose sister died. So I can tell you that people feel the pain still.
Yeah.
So they're glad this is happening, but
Yes.
but let's not disappoint them.
Yes, because when the arbitration thing started, one of the, I would say, the objectives was around redress and closure. Whilst a lot was done by the arbitrator, but the issue of redress and closure, I don't think it was fully dealt with. And that's why maybe we're hoping that when the inquest comes about, things will be taken to a level of accountability, which is something that we don't always find in South Africa. People do wrong, they are moved aside, and over time we forget about them, and then they get redeployed in another area of responsibility without any accountability for what they may not have done well. All right, so now if we just look at what is it that civil society needs to do. I'm saying civil society because when one looks at what you guys managed to achieve with the treatment action campaign during the time of the AIDS denialism, it was clear, that the pressure from civil society and also going to court made things to change a bit. Now, when it comes to issues of mental health, do you think South African civil society is actually, sensitized and pushing enough for change, so that, because there was this recovery plan that was supposed to come up, post Isidimeni, that was supposed to ensure a better, standard of care for mental health users.
I don't think that it is. I think that there are a small number of organizations that do heroic, marvelous work on mental health, like the South African Depression and Anxiety Group. They are heroes, really. I mean, during COVID, the number of calls that they get on a daily basis has doubled. They speak to, I think, 1,200 people a day who are desperate, many of them who are suicidal. But there isn't a broad civil society movement around mental health. There are organizations that do a little bit of work on it, like Section 27, in representing the families. But I think we need a much stronger civil society understanding of mental health and ability to organize around mental health. As we both know, mental health is very stigmatized, just like HIV was stigmatized. People don't want to talk about it. People don't want to be open about having mental health illnesses, mental health problems. And that makes it difficult to organize. And it's something we have to we have to think about. When we started building the treatment action campaign, we were a handful of people. There wasn't a big movement in 1998, but we did understand that unless people living with HIV became the battering ram, their own battering ram for treatment. And so people with HIV, learned the science, learned about the health system, became their own advocates, with the assistance of other people and other organizations. And I think that the same thing has to happen with mental health. But the other thing that I would say, Dr. Nyati, is, mental health is obviously, it's everybody's issue. So it shouldn't just be health NGOs that work on it. Mental health seeps into every area of our society now. And if more people were aware and understanding of how present mental illness is in our society and what are the drivers and the determinants of mental illness, then as a society, we would be better positioned to manage this this crisis that we have.
Yeah, just reflecting back on the award, there was the thing about the monument of some kind, and also the payouts to the families of the deceased or the survivors. It seems like that has not been completely sorted out almost 5 years later.
It hasn't. I mean, most of the payouts have taken place. I can't say that all of them have taken place, but most of them have taken place to survivors, family members. There's no monument still. That hasn't happened. And you mentioned a minute ago the recovery plan. I don't know what's happening with the recovery plan, but what I can tell you is that Esidimeni didn't cause an improvement in the quality of mental health care services across our country. The Human Rights Commission issued a report 2 or 3 months ago based upon its investigation. It in fact tabled that report to Parliament a few months ago. And I hate to say this, but in certain circumstances, the conditions in which mental health care users live are horrendous. And we still don't have the necessary medicines in our clinics. We don't have enough psychiatrists, enough psychologists. There's so many things that need to be done. And as I'm saying this to you, I'm thinking, how government says we don't have resources, we don't have budget, we can't do it, we can't employ people to do this. But it's short-sighted, because if you don't treat mental illness, then the cost increases, the cost to society increases in a whole number of ways. This country has 23 suicides a day. I think that's the figure, 23 a day. We have children, we saw that horror in the school in Limpopo recently, children as young as 10 committing suicide. When somebody commits suicide, there's a cost to themselves, they lose their life, but there's a cost to their family, because they may be a breadwinner. The suicide may mean that the family's last few cents have to go into the funeral, so there's a knock-on effect. And that's our problem, is that we're constantly short-sighted in the way that we approach health problems. And I guess some people who perhaps most need to be educated about these things are the people who work in Treasury, understand that it's a fool's saving to think that if you cut finances now, that you're actually making a saving. You're not making a saving, you're making a new cost.
Yes, yeah. So if we now try and move and just take this Isidimeni experience and say, is that a symptom of our healthcare system that has got challenges? What lessons are we learning from that? But looking at the broader healthcare system, mindful of that Section 27, that right of access, for everybody in the country, to quality healthcare.
Well, Isidimeni is symptomatic, and I'm trying not to be too pessimistic in this conversation, because there's always this tension between the innovation, the capabilities that we have, the physical and the human resources that we have, the goodwill that exists for the healthcare system. All of these are things because you work in the healthcare system, and our failures. And somehow we have to rally and build the goodwill and capability so that we can actually impact on the system as a whole. I feel it needs leadership to do that, to lift people's morale about what we are capable of doing. We saw it beginning to come a few years ago. I'm sure you were there, that National Health Summit. Everybody comes together, but as often happens, they come together. Government spends probably 25 million rand for 3 days in a conference. Everyone gets excited, and then nothing happens. And the challenge that we face, Dr. Nyati, is COVID-19 is a game changer to the health system. It will break something that was already broken if we don't have an emergency plan. COVID-19 has set us back on HIV, on maternal mortality, on tuberculosis, on infant malnutrition, just about everything, you name it. It has set us back. It has taken away a layer of healthcare workers, and you and I know many of them, some of our best brains and experiences have died because of COVID-19. So we should be ringing bells somehow and saying we have to find a way to rally to fix this healthcare system, because if we don't fix it, it will have effects for decades to come. We're still now dealing with our failures 20 years ago to deal with HIV properly in the late 1990s, in the early 2000s. Because of that, we got a generation of orphans. There'll always be orphans. There was a developmental impact. The same thing is going to happen again. So I don't want to be pessimistic, but we have to be realistic.
Yes. All right. Maybe let's just move a little bit now to, you wrote an article sometime this week around fires.
Yeah.
Somebody else will not have seen how those fires can be joined, the dots. The fire at Charlotte Maxeke, the fire a few years ago at the head office of the Gauteng Department of Health, the fire in Cape Town, what made you join those dots and actually feel like, I need to write something here?
Because I think people have to join the dots all the time, as much as possible. And if it sometimes requires me to do that, then that's what I will do. And it just struck me, the connections. The fire in Cape Town was not an act of God. It was a disaster that was waiting to happen for a variety of reasons, some of which are related to climate crisis, some of which are related to the way we manage our environment, some of which are related to our lack of preparedness for disasters in this country. The fire at Charlotte Maxeke was not an act of God. It was a disaster that was waiting to happen. And I needed to show people that it was a disaster that was waiting to happen. And again, as these things struck me and I had these thoughts, but then I went back to check on certain things. And, you mentioned the fire at the Bank of Lisbon in 2017, the Gauteng Health Department headquarters. There's still not a public report into that fire. We lost 3 firefighters' lives in that fire. Many of the factors that caused that fire, although that fire may have been deliberately set, were factors that play out now. And again, it goes back to what we were discussing a few minutes ago, which is that you make these short-sighted, self-defeating cuts in funding for health systems that then cause a much greater expense later on. I mean, I've been talking to people who work in the fire service, for example, and it's shocking, how you think that we have a fire service. Well, we don't really. If there had been another serious fire on the same day as the hospital fire, we wouldn't have had anybody to send to it, because we're not a city that can manage 2 big fires at the same time. So I guess that's all of our job, is to join dots. If you see things just as isolated incidents, then you don't see what can be done to fix them. And I guess whenever I write, I'm not writing because I like being a critic or I get pleasure in pointing to failures. I'm writing because I hope that somebody will read it and decide on how to prevent this type of thing from happening again.
Yes. But if we now just try and maybe be more positive, when we just when we look at the health system in general, or even in mental health, what positives do you think are there, so that at least we are not seen as people who just were critical of everything? From your vantage point, especially during the time you were at Section 27, and also now that you are monitoring these things as the editor of Maverick Citizen.
Well, we have many positives. I mean, we have probably one of the biggest health infrastructures of any country in Africa, physical infrastructures. If you put together our private health infrastructure and our public health infrastructure, we have a great health infrastructure. We have clinics, we have hospitals, we have district hospitals, we have academic hospitals and tertiary hospitals. We have some of the most experienced infectious disease specialists in the world. We have some of the most experienced trauma specialists in the world, unfortunately, because of the level of trauma that we have in our country. We lead the world on HIV, on tuberculosis. We lead the world's understanding on HIV and tuberculosis because of the research institutes that we have, that we developed here as a result of the COVID-19 epidemic.
Even the genomics, in COVID-19. I mean, we are leading there.
Exactly. And although I think that there should be more money for health, we do have a lot of money for health comparative to other countries. I mean, we spend 8% of GDP on health, which is actually quite a lot compared to other countries. That's the combination of the public and the private healthcare sectors. You should get much, much better outcomes. But the problem is that probably about at least 50 billion rand a year is stolen out of our health system. So if you prevented that money being stolen, we would have a better quality of healthcare system. If we regulated health better, we would have a better quality of healthcare system. I was chatting to people from the National Council Against Smoking 2 days ago. Smoking costs, I'd have to look in my notebook. I wrote it down somewhere, the exact figure. But smoking costs the health system like 30 billion rand a year or something. Now, if you do more to stop smoking, that 30 billion rand, instead of being on preventable cancers and diabetes, can go into other aspects of care. Alcohol. What does alcohol cost our healthcare system? What does malnutrition? So it's not as if we have this discussion and we're saying we don't have instruments. There's nothing we can do. There's 20 things that we could do that could be making a big difference. And that's why I'm optimistic. And I'm also optimistic, the last point in this question, because I think we have wonderful healthcare workers and we don't recognize them enough. They work under strain. There's a few bad apples, but we have people with heart still in the health system.
Yeah. And so the discussions then around NHI or universal healthcare, what are your thoughts around that? Do you think it's a panacea to the challenges that we have as a country?
No, NHI is not a panacea. I support the principle of universal healthcare. I support the principle of national health insurance. I support rational measures to make our health systems more equal and to make funding not an issue, not a barrier for poor people to have access to healthcare. I think that the NHI bill that's on the table at the moment is very badly constructed in many respects. And they're going about it the wrong way. So I'm a critic of the bill, not of the principle that it needs to happen. I see they've just appointed Dr. Nicholas Crisp as the head of the DDG of National Health Insurance, which is probably a good sign because he's a pragmatic person with a lot of experience in the public healthcare system for many years. But again, Fundile, we have things we could be doing that could be creating more equity, and we're not doing. So let me give you an example. You know about it. A few years ago, we had a very expensive inquiry into the private healthcare system. The health market inquiry. And it was chaired by Justice Ngobo. It had experts, and they spent a lot of money on that inquiry, ridiculous amounts of money, 100 million rand. And they produced a report with many, many important recommendations that would lead to better regulation of private healthcare. And if you regulated private healthcare better, it would make private healthcare cheaper and more sustainable, which would take some of the burden off the public healthcare system. It would improve systems of governance in the private healthcare system. But nothing has been done on that report. That report is sitting with nobody doing anything about it. So why do we do these investigations? Why do we create this knowledge? And then we don't do anything with it. So again, we have these grand ideas about NHI, but we have fairly simple things we could be doing that would help build the platform, the foundation for NHI.
All right. No, but anyway, I think looking, are you optimistic though that things can be better if we all put our hands together and do something about our healthcare system?
Yeah, I'm well, yeah, yes, I am. Um, but it takes work. It
Yeah,
will take work
yeah,
from all of us.
yeah,
Unless we act soon, then
yeah,
we're going to cause so much damage. We will spend a long time trying to repair the damage. But it's just like our country.
yeah,
We have a wonderful country. Is it in a mess at the moment? Yes, it is in a mess.
yeah,
Do we give up? No, we don't give up. We work to try and fix the mess so that we can realize the potential that we have within this country.
all right,
We try to get the good men and women, of which there are many, they outnumber the bad men and women, to become a force that
yeah,
can bring about the changes that we need.
yeah. All right. So as we wrap up, Mark, what closing remarks or parting shots, to the viewers out there who've been listening to us talking around issues of mental health, our healthcare system, and generally, that we still have a potential to correct things as a country.
Yeah, I mean, I think I've said it all. I mean,
Yeah.
we've talked about mental health, and to people who are watching and listening, you have to take mental health care seriously. We have to be more open about mental health care. Mental health care isn't about somebody else. It's
Yeah.
about you and me.
Yeah.
And so we have to see that we may have mental health care issues that need assistance. And like HIV, openness will be beneficial to everybody.
Yeah.
Seeking care and diagnosis will be beneficial to everybody. So that's on mental health, and we have to support those who are doing the work on mental health. I mentioned SADAG a few times.
Yeah.
We
Yeah.
have to make sure they have the funding that they need to continue, that they can grow, not shrink. On the other issues, I guess we haven't talked about it much today,
Yeah.
but
Yeah.
we are still far from being out of the woods on COVID.
Yes.
India, what is happening in India
It's
should be
bad.
awakened to us. We
I
thought the
mean,
second wave was bad. I
yeah.
don't know what the third wave will look like, but there will be a third wave. And so we have to get out of that hole still. And every person has to be thinking, how do we get out of that hole? We have to speed up the vaccine
Yes.
program, and we have to create pressure. Every person listening now has a role to play in trying to help other people to overcome hesitancy about vaccines,
Yeah.
to counter misinformation about vaccines. So the message is there's lots to do.
All right. On that note, Mark, I must thank you. I had planned to just use 60 minutes of your time, and we've just gone over by 5 minutes. And it's a Saturday, so I can't use so much of your time. So I just want to thank you for making time, and I'm sure it's not the last time I chat to you. I read quite a lot of the stuff that you guys are doing at Daily Maverick. Every morning I get an update of what's new, and it gives me a good picture of what's happening. And so please continue doing the good work, and because by you doing that good work, some of us get to be informed and we know exactly, where we can make a difference. So thank you very much for, giving me your time.
And thank you for the great work you've done over many years as an advocate for health, and as a doctor, and as an activist for the right to health. So thank you. It's been great having this conversation on a Saturday afternoon.
Thank you very much. And I just want to thank all our viewers as well who logged in to follow this conversation. Thank you very much. We don't take your sacrifice in terms of your time for granted. We appreciate you following our conversations, and we will continue to bring people who are knowledgeable, who are leaders in their areas of of passion, so that we can be able to all of us play a role in one way or the other to improving our health and also the health of our nation. So thank you very much. Until next time.
Thank you.